Thanks for joining us for this special opioid overview reports session. Today I've got Bobby Brummel from the Iowa Healthcare Collaborative data team joining us to help explain some special reports that have been developed over the past year. These reports were originally developed for hospitals that were participating in the opioid guardianship program. And now, based on hospital feedback, we'd like to make these reports available to all Compass HIN hospitals. Today, we'd like to provide you a background of these reports, explain to you the data source used, and the time frame pulled to populate this information. We're going to overview the Iowa opioid report and also the facility-specific opioid reports developed for your use. Each of these reports has an associated data dictionary, and we've developed an ICD code list to help you understand which codes were used in the development of these reports. We'd like to leave you with our contact information so you can continue to reach out to us with any questions you may have about these reports. So once again, as we get started today, background of these reports, as Compass HIN strives to continually provide you useful data that you can use to drive improvement in your own organizations. We've tested the use of these facility-specific opioid reports to help facilities identify different populations at risk and potentially help design interventions that would help meet the needs of their community. These reports are also used just as an awareness and education tool for hospitals and their communities. Now I'm going to hand it over to Bobby Brummel, from the data team to give you an overview of the Compass HIN reports.
So just some background information. The time frame for these reports, for both these reports, are January 2016 to the end of January 2017. And the data source for these two reports are both come from claims, IPOP data. So just getting into the overall Compass HIN Iowa reports. I'll just be going through these, kind of overlaying it a little bit. So starting off here, at the very top left corner, you can see just quick numbers of total prevalence of opioids that we considered in this list that we will go through later on, which ICD codes we included. So you can see total prevalence. You can see it broken down into primary additional diagnosis, inpatient, outpatient, abuse and poisoning opioids. Kind of going over, you can see the time series of total prevalence. That is aggregated by quarter and not month or year. And
Bobby, you're looking at the table in the top center, which is CH1.01, correct?
Yep, that's correct. And then going over to CH1.02, prevalence by month. That's just looking at the opioid, both abuse and poisoning, prevalence by month. And for a record to be considered into this graphic, it must be of inpatient status to be considered. So it's not looking at any of the outpatient opioid coding. And then kind of going down to the second row, you can kind of see the three time series graphics of primary and additional diagnosis, inpatient, outpatient, and abuse poisoning over time within our time span. And then kind of going down to the third row, looking at CH1.06 top primary ICD codes. Those are the top, obviously ICD codes that were recorded as primary diagnosis that were included of our opioid coding listing. So you can kind of see the top codings that have in prevalence within the states of Compass HIN. And then kind of going back in the same notion that for graphic 1.07, this is additional diagnosis prevalence. And you can kind of see the codes there, pretty similar. You get more of the abuse codings there with the F codes right there. And then 1.08 is a little bit different. So this is only looking at additional diagnosis, opioid additional diagnosis, but then looking at, what was the primary diagnosis in this case. And so I know the first one there, A419, that's actually of sepsis. And so
So basically, Bobby, is that saying in CH1.08 that of the codes that showed up with opioid as an additional code, you're looking back to, well, what was listed as the primary, and one of the top ones showing up is sepsis?
Yes, that's correct. That's the right notion I'm thinking about it. It's a little bit different because that's, those codes aren't obviously opioid coding, so you can kind of get mixed up, looking at, if you looked up those codes. And then going on to 1.09, those are just the top discharges when opioid, was prevalent in our coding listing. And you can also see home and self-care is at the very top of the list.
And this is discharge disposition of folks with an opioid diagnosis as the primary?
So this is looking at all, both primary and additional diagnosis.
Okay. When they were discharged, where did they go?
Yep,
Great.
That's correct. And then 1.110 there right next to it, it's looking at prevalence by weekday, and then when it was a opioid primary and present on admission, and that's a red line right there. So you can kind of see the little differences, I guess. On weekends, it's more, likely to be primary present on admission, when relating out to its own line, as opposed to just looking at prevalence. And then kind of going down below to patient demographics. So these counts are a little bit different because these are just unique patient counts, while the overview prevalence count is just looking at the total number of opioid diagnoses that were charged, if that makes sense. And so 1.11 there, sex distribution, you can just see, female at 54% and male at 46%, and that's of opioid prevalence that we have for record ID.
If folks were wanting to look back and tell for certain graphics listed on this report what data specifically is pulled, is that where they would reference the data dictionary?
Yep, that's correct. So all of these graphics kind of go into, really specific detail on the data dictionaries, and they're pre-mapped out to show, what was included, and what was listed and how they're ordered. And so they're pretty easy to go through.
And this is what the data dictionary looks like. There's a Compass Hin. You can read the title at the top. This is the Compass Hin CH Opioid Dictionary, and you can see that each table is listed by number, and you can go back and correlate that with the graphics. So we'll provide those to you as well with each of these reports.
Yep, that's correct. And then going next to 1.12, that's just grouping the total prevalence by the age of the patient. So you can kind of see the 21 through 30 is kind of higher, same with the 51 to 65. And then if you go over to the next graphic, 13, that's basically showing the same thing, except it's broken out by additional and primary diagnosis. So you can really see that, primary, if you have an opioid primary diagnosis, you're probably going to be around the 20 to 30 year old range. While additional diagnosis, you still hit those two, key age groups, really emphasizing on the 51 to 65-year-old demographic.
And they can tell that the orange line or the peach line is the additional diagnosis, and the red, dark red, is the primary, using the key right underneath graphics on CH1.13.
And then going over to the next column there, CH114 and CH115, just looking at top race and top ethnicity in the state for Compass Hin opioids. And then going down below to the very bottom row, CH116 total prevalence by county. So that's just looking at patient counts for opioids. You can obviously see that Polk has the highest, and then it's kind of mapped out or listed out in 117, where it's listing those counties with counts. And as a background, these are where the patient lives. This isn't necessarily where the patient went to get treatment facility-wise.
Yeah, so it's not mapped by hospital county, it's tracking patient residence zip code. county. Got it.
Yep, and that's the same thing with the next graphics over in 118 and 119. This is looking at prevalence per 1,000 population for the county. So you can kind of see the differences between the two maps. You know, you get kind of high rates in some counties that had, you know, necessarily lower rates and prevalence counts.
So Bobby, in graphics CH1.16, here in the bottom left-hand corner, you're using the scale of counts. So 5 is the bottom threshold it counts for that particular code, and 911 is at the top. And so they can use this color scale at the bottom to map that county's count.
Yep.
And then here it's using the same thing, but they'll note that the scale is different using the rate. And so that's why on one map they might be blue and on another map they might be red. They need to correlate with the scale. Is that correct?
Yeah, that's correct. The color scales are still the same though. So when you're in dark blue, you know, you have the lowest, while if you're in darker red, you're in the highest for that map.
So this Compass In report is 2 pages long, and so this is the second page of this report we're moving on to now.
So yeah, the second page, so starting off, it breaks it down, these opioids by reasoning. And so you can kind of see in 2.01, top reasoning prevalence, undetermined, accidental, and self-harm, lowest most likely. And then you can kind of see next over, the time series graphics of all those plotted out. You can kind of see the legend, see how they correlate. And then in 2.03, this basically just takes a deeper dive into the accidental top reasoning at looking at discharges. And this is, once again, looking at all primary and additional discharges for accidental reasoning. And then I do the same thing, except in not using accidental, but using self-harm for 2.04, looking at top, discharges. And it kind of correlates a little bit, you can kind of see the home and self-care or the short-term hospital, that they have in common. Going down to the second row, 2.05, this is just looking at the average length of stay, that they have, kind of, similar, just by a day, accidental at 4.1, the patient stays there on average, self-harm still at 3.1, so still pretty similar. Diagnosis by reasoning, this is just looking at the breakouts of inpatient, outpatient for both accidental and self-harm. You can kind of see accidental, more people kind of by twice the rate are coming into the outpatient and inpatient. Then going over self-harm by quarter, just a deeper dive into self-harm and looking at, the differences in quarters for the 2 years that we analyzed data. You can kind of see the quarter 3 is a lot more prevalent than the rest of the quarters. And then just looking at self-harm, sex distribution, I thought this was interesting. Looking at the, how females are a lot more likely to, have an opioid of self-harm than males. And then going down next to the next, section there, this is kind of more looking at, specific drugs and kind of breaking it down, by specifically, I guess. So the first graphics just kind of showing, top specific drugs, 2.09. A lot of these codes, get clumped together as other narcotics or other opioids kind of grouping like that. But you see heroin's still kind of up there with those kind of clusters. Then going over to 2.10, you can see that I mapped out the, some specific drugs, and that the clusters. So you can kind of see the legend there and see how they kind of correlate. You can see that heroin's still kind of a lot more prevalent in the States than meth and opium.
So you're talking about this color legend with heroin in orange, meth in green, and opium in yellow correlated with these charts.
Yep, that's correct. Yep. And then kind of going over, kind of more looking at, heroin at 2.11, just the time series, and kind of see the trend line there, where it's going Heroin, as far as admissions, you can see that, even though the weekend only consists of 2 days, still makes up 40% of the heroin admissions. So that's kind of interesting. And then going down to the next line there, 2.12 or 2.13. This whole row is kind of more a breakdown of heroin. So you can see there that more people are coming in to the outpatient than the inpatient. Sex distribution there in the next graphic. Really high target for males within 20 to I would say 30 years old, and then it kind of drops off both the males and females at around 35 years old. And then just the map, just like before in the first page, the heroin per 1,000 people per county. Still the same thing. So if you have a dark blue line, then you're at 0. And if you're at the very highest at 0.7, then you have a dark red. And then basically, if you don't have any colors on there, then you just had no, heroin prevalence in that county.
For this time frame.
Yep, that's correct. Then you can see the top heroin per 1,000 counts in the next visual over in 2.116. And then the next section is looking at primary opioid diagnosis when it's not present on admission, but it got tagged on to their record. And so you can kind of see in the first graphic there, 2.17, primary diagnosis not present on admission. So you can see that, when people come in, most of the time they don't come in with it being present on admission, as opposed to them coming in with, an opioid overdose or poisoning. And then you see, the time series graphic next over in 2.18. You can see it's rising in the state in our time frame. And then in 2.19, not their top primary not present on admission. These are just the codings that get tagged on. That's have the top counts for this specific query. And then 2.20, top additional diagnosis. This is only looking at first additional diagnosis, not present on admission. So the same thing there. You can see the codings there. And then in the next one, 2.21, top additional diagnosis, not present on admission. So this is just like the same thing that we were talking about in the first page when, there is a additional opioid diagnosis in the additional coding, but this is looking at the primary diagnosis. So these codes aren't necessarily opioid codes, but this is just kind of looking at, if you can find any correlations part of it.
Great. Thanks for sharing a little bit more detail about each of these graphics. As you guys can tell, there's a lot of information included in these comprehensive opioid overviews. And so that's why we knew it was important to provide you with a little cheat sheet of which codes were included in this data pool. Bobby, can you explain a little bit about this opioid ICD code list?
Yeah, these are all the ICD-10 codes that we use in the study. So what we considered in counts, had to have an ICD code up in this list. There might be other opioid codes, out there, but if they are not in this list, then we did not consider them. And you can see the breakdown between abuse and poisoning. Abuse codes are just the top 3 ones, and those are highlighted up there. Everything else is poisoning. And then you can even see, in these descriptions, what was self-harm or accidental. You kind of see some of the reasoning and what we use in these different sections. And I break it down into, in these data dictionaries, claiming, what we use for each graphic and visual. And so it's pretty straightforward.
Great. That's, I think, very helpful. As we mentioned earlier in this tutorial, there is a data dictionary that you can use that helps describe each graphic. So if you're using the Compass HIN overview, make sure that you're referencing the Compass HIN or the CH opioid dictionary. Let's move now and just talk about the facility-specific reports. Here's an example of one of these. And Bobby, as I understand, these are one-page in length.
Yep.
And they share a lot of similarities with the Compass HIN report, but just at a facility-specific level.
Yeah, so these specific reports, all hospitals will get this report of their own data, and they'll all be one page long. And basically all these graphics on here are just a subset of what you saw in the Compass HIN Iowa opioid overview. And so kind of getting into it, prevalence, just like the Compass HIN one, there's a panel there and looking at total prevalence at your facility specifically and kind of breaking it down by primary, additional, inpatient, and outpatient in the use and poisoning.
So 66 times for this hospital, Bobby, from the dates pulled, and that shows here at the top, there was 66 times when an opioid code occurred.
Yep, that's correct.
Okay, great.
Yep, that's correct. And so that kind of goes hand in hand with the next graphic there. Total prevalence in SP 1.01, just looking at it as time series. And again, this is by quarter, yearly quarter. So each year should have 4 points on the graph. And this is not by month or year.
And then this is also looking like the same as the other report, but it really looks at when these codes are occurring, if there's any trends that they can appreciate by day of the week, and also by quarter or by season over here on the right-hand side.
Yep, that's correct. And just to point out really quickly at 1.02, admission by weekday, this is only looking at inpatient patients, people who come into inpatient, not outpatient. So you might see differences in the number of counts in this graphic as opposed to total prevalence.
Mm-hmm. What are the other differences they might see in this facility-specific report when comparing it with the Compass HIN overview?
So I think the only difference is obviously this is your own data. And I think as far as graphics goes, I think the only differences in graphics are SP 1.03, looking at accounts by season and quarter. Everything else in prevalence is the same except for SP 1.11. I believe we didn't put that in there, but that's just because we broke it down more graphics into the Compass HIN one. Wow, this is just like a quick snapshot of the data looking at, was the primary diagnosis present on admission or not for opioids.
At your facility.
Yep, that's correct.
And then can you talk a little bit about this age grouping with this peach color at the bottom being primary and the darker red being additional?
Yeah, and so this is just grouping all the counts of total prevalence by age group, and it's just colored by primary and additional. So you can see that, if an opioid was an additional prevalence, then it's dark red, while if it's in the peach color, it was a primary diagnosis of opioids. So you can so that's just added on there just to help you, get more insights of, what kind of patients you're getting into that age group. Because like we kind of saw in the Compass HIN reports, you're a lot more likely to come in with an additional diagnosis if you're in the 50s to 60s age range. But everything else in this patient demographics are the same as far as counts by race and ethnicity, and just looking at where your patient's coming from that have opioid diagnosis in the county, in the state map.
Are there any areas, we mentioned earlier in the tutorial that these facility-specific reports were originally developed for hospitals participating in the Opioid Guardianship Project. And so was there any learnings in the feedback we received during the project period as far as commonly asked questions from hospitals or common misunderstandings hospitals had when they started using these reports?
I think the main thing was just the differences between the prevalence and patient counts. So prevalence is looking at all, number of how many times the code showed up. So a patient could have 2 additional opioid counts, and that would be counted as 2, while the patient demographics, that would still just count as 1 patient. So there's just difference in count. So we got that question quite a bit, and just kind of smaller questions, I would say, as far as like the counties, you know, if that was, you know, where the patient was from or how they were getting that. And then just like the time series stuff, you know, those are just by quarter, not by year or month. And then I think the only other real question was, if your graphic or table shows up as a blank, that just means that you don't have any counts for that specific graphic.
For this time frame pulled for the report.
Yeah.
So if a facility shows one of these tables as blank, that just indicates that there was no data to populate it?
Yeah, we had no prevalence or no record in there for that specific graphic, I guess, for, you know, that facility.
So this facility-specific report also will have a associated data dictionary labeled SP that they can use to correlate the data for each of these graphics, and we'll encourage your hospitals to use that as you begin evaluating these reports. We want to thank you so much for your time today. We're happy to be able to provide these reports to you at a facility-specific level, and welcome your questions and comments as you review the material. Bobby can be contacted at the email and phone number shown, or we would also encourage you to continue contacting your Compass 10 clinical quality consultant, either Ashley O'Donnell, Michelle Bonson, or Lana Comstock. Thank you so much for your time.